Let's get the meeting started. There are a few groups here, the stakeholders that would like to leave early. And so we can sort of shift this thing around. We have, first of all, the meeting called to order. And what time is it? Is there?
3:07.
3:07. At 3:07. And we have the minutes to approve.
Motion to approve the minutes as presented.
I went over them. I will second them.
All right, we have a first and a second call for the question. All in favor?
Aye.
Minutes approved. We
Madam-
go on to the presentation. Yes, sir?
Before the presentation, Madam Chair, if I can go over your packet,
Okay.
because you also wanted to do some planning based on what you've done, and so you have one handout, well, you have one handout that has all the members.
Okay, yes.
Then you have your survey that you did of all of the stakeholders and their responses on 6 questions. And it's all on one page, and the ones who answered was SCAN, Board of Region, AMA, Pillar, West Care, and the Health Department. The questions are, do you provide drug and alcohol services? Each one answered. What services do you provide? Each one answered. What groups do you serve for drug and alcohol services? You have their answers. What do you consider the 2 to 3 priority areas for treatment and prevention? You have their answers. What do you consider the most important action needed to address this public health concern? And you have the agency's answers. And then, do you use any of the treatments and for what? And specifically, the commission has methadone, naloxone, and you have their answers. So this is one tool that you all did and developed. You have a second tool that you began to form your own goals and objectives. And that was something that Mr. Thompson worked on primarily, but then everybody participated as well. And so we gave you the answers that each one said as different goals and objectives for the commission. And again, yours is to go through it at your leisure and discuss it. You also updated the directory of services, and in your packet is only the table of contents. Chief Torres has the full copy. We still need to add Gateway, their new program. But all of you were saying how we can still make this more user-friendly, and I think Ms. Rodriguez was already touching on some of those. Then you have what SAMHSA and the Department of Health and Human Services considers detoxification, which we had lengthy discussions throughout the meeting about medical assisted treatment services versus cold detox, which is really not used anymore. But this has the standard of care that the U.S. Substance Abuse and Mental Health Services Administration puts out. That this is what they consider the standard of care for detox and substance use. This is the executive summary, so you'll have this. So that's your packet, commission members, that you have. And the agenda for today was for you to discuss these items, the work that you've done, develop next steps, because you all already want to post a lot of this. You created a web page. You want to make the directory more user-friendly. And I think also those are great steps, because we need to get this out, this information out. And then you have the presentations and concerns and gaps from the providers and stakeholders. So it's at your discretion, Madam Chair, how you want to proceed. But yes, some of the groups need to leave early, so are asking if they can present.
Well, we need to go through. Do you want to do any of the planning or discussion of anything before we ask them to present?
No, maybe we should, we do have a RSVP from Mr. Thompson and from the other, so then maybe switching it around for the stakeholders that are here. Doing the presentation, I guess, once everybody, we have a better forum per se, we can do the planning and all that, so we can get their input rather than having to repeat and rewind. Yeah.
Okay, well then let's start with the presenters. What do you want to do, alphabetical order? I don't know.
It's up to you, Madam Chair.
So-
You've got scan here and you've got Puerto Rican.
Weren't this presentation gonna be on at 5?
Yes, but some have to leave early or asking, so, no, you can present at 5.
Oh, okay.
You can present at 5, that's not an issue. But I think Puerto Region has to leave, so.
That's fine.
Yes.
Yes, I noticed, you submitted all of our programs, but I noticed that Puerto Region isn't on the directory at all.
No, it is.
Oh, it is?
is.
Okay.
We just took a snap of the table, and Puerto Rican should be here.
Hello. Hello. Hi, good afternoon.
Puerto Rican is there, and this is just the initial.
Okay.
I brought the laptop just in case I wasn't around.
No, this is the most up to date. Maybe I didn't copy the court page that has the rest of the agents. But Puerto Rican is here.
No, that's what we're gonna bring up at the, right here, the webpage and all that stuff. Look at the files. She's asking.
That's true.
The thorough version, you know, on the table of contents are there.
It's working. Yes.
How are you, sir?
Oh, you wanna do it? Go ahead. For the record, we're gonna do 20 minutes per presentation, and Mr. Lozano's gonna be taking care of the time.
Okay. Will you let us know, we have like 5 minutes?
Yes, I will. Well, not sure.
Okay.
No, we got you.
Okay, thank
Let us know when you're ready to start.
It's working, okay. Good afternoon. My name is Laura Kim, and I will be discussing the children's unit. And to my right is Miss Mary Lou Ibarra, who is the assistant program administrator. And to my further right is Miss Gracie Vela, who's the director of substance use program there at Border Region Behavioral Health Center. So thank you for having us here. I'd like to start, and let's see that I can work this PowerPoint clicker. Please.
There it is.
Maybe if you put it on the part. Yes, yes. We're having technical difficulties, so we'll get it squared away. Okay. Border Region Behavioral Health Center has been established since 1997, and it was formerly known as Border Region MHMR. Prior to that, it was managed by the local state center, so some people refer to it as the local state center or MHMR. They don't know it as its new name as Border Region Behavioral Health Center. And we offer services to the counties of Webb, Zapata, Jim Hogg, and Starr County. And in each of those areas we duplicate the same services. Children's, adults, as well as the intellectual and developmental disabilities areas, which is, it's a mouthful, but you may know it as, it's not politically correct, but it's the Down syndrome and the mental retardation population. The populations that we serve, it exceeds a little over 3,500, and we're serving in the children's unit double the target areas. So we're supposed to serve about, say, 784, so it's 1,400 constituents. And we assist children as early as the age of 3 to 17 years of age. Border Region is trying to adopt a new vision as a trauma-informed care center. And because of this, our vision statement says that we pledge to provide a shared culture. And you're asking yourself, well, what does that mean? We want to provide a safe, provide healing, accepting, respectful, diverse, and empowering culture.
Did I do it again?
That's okay. I'll handle it from here. Thank you. Our CAPS unit is our children, adolescent, and parent services area. We have a crisis hotline that is available 24 hours a day, 7 days out of the week. The number is freely available to all and to many. And if you ever know of someone who is in need of services, feel free to write down the number. It's 1-800-643-1102. And usually we'll have someone there's a system called, help me out here, Avail, and that becomes activated. Then the individual could be seen in the hospital, and this could be the weekends, this could be at various different, and we partner very closely with our Laredo Police Department alongside with our Webb County Sheriff's Department to help to render aid whenever we're undergoing a crisis with our clients. Any questions? No? Okay. In the CAPS unit, we have service access, pharmacological management, provisions of medication, case management, rehabilitative skills training, family partner supports, parent support groups, crisis intervention services, the mobile crisis outreach team, jail diversion, and our intervention settings are within our office. We go to the community. They're conducted in the school as well as in the in-home based interventions. We also have a more intense case that's called the Youth Empowerment Services, which is the YES waiver. And these are for much more serious cases that require the one-on-one adaptive aids, equestrian assistance, whether it's they need to take music therapy, they need to be taken out into their environment to have one-on-one to help them as support aids. There's pet therapy, we have respite. Does everyone here know what respite is? Yes? Can you tell me what respite is?
We have in-home service provided by a provider for your loved ones when they're in their last stages of their life.
Yes. Now here it would be more so, respite is that someone needs a timeout and they need an intervention of some sort. Either the individual is going through a severe crisis, whether they're hospitalized and they come back, but the family needs a little bit of a timeout per se. So we offer that in the unit as well. And transitional services, when they're discharged from the hospital, and we try to intervene with them so that we know what the next steps are, to make sure that they're taking their medication, to make sure that they're doing well, and to follow up. Medication training and support, intensive case management, crisis intervention. It's pretty much the same, but it's in a more intense level. Thank you.
Good afternoon, everybody. Hello? Okay. Good afternoon. My name is Riley Ibarra, and I'm one of the administrators for the adult unit, so I'll be speaking to the departments and the services that we provide in our adult unit. All of these services are provided to our adults that are 18 and over, and they have to be voluntarily coming in for services, okay? We get a lot of different questions from family members as far as what can I do to help a loved one going through a crisis. So some of these services that I'll go ahead and go through will answer some of those questions. If not, please feel free to let me know if you have any questions, okay? When someone comes into our services, they first go into what we call service access or intake department. That means they're requesting their service or their case to be open with us for a number of things that we can provide, or services that we can provide. They come in, that first intervention is about a 4-hour interview. They see a case manager, then they see an LPHA, which we also known as an LPC. They are determined to see if they qualify for services. We have a priority population that basically we look at as far as what the state guidelines gives us, and those 3 diagnoses are bipolar disorder, major depressive disorder, and schizophrenia. Now, these 3, if you're diagnosed with one of these 3, more than likely your case will be opened. And again, all services are voluntary. Once their case is opened, then they're assigned a case manager. They're also provided some of the services that are here on the screen. Our main focus is to educate individuals on their diagnosis, any medications that the doctor or our psychiatrist has provided to them or prescribed to them. Through case management services, learning what your diagnosis is, learning how to cope with it, how to live a productive life in our community and integrate into our community with a diagnosis. And some people will experience symptoms even with medications. How do you function and continue to function in our community in a positive manner, even experiencing some of these things? So this is what our case managers do. We provide services in an array of levels, from level of care 0 to a level of care 4. 0 being the least intense, which is a client who is more independent, will come into the doctor maybe once every 3 months, 4 months, depending on what the doctor has prescribed. And our level of care 4, also known as our ACT team, is our most intense group. They get seen about 10 hours a month, and they get services at least once or twice a week, and it can be in the clinic or in vivo, which means out in the community. We provide services to our clients in their homes. We take them out into our actual community and help them go through maybe an anxiety or any type of situation or symptoms that they experience while being out in the community. Our goal is to walk the walk with them and show them and teach them how to overcome some of those obstacles that they're experiencing while they're out in the community in order for them to return to school, in order for them to return to work, just be a productive citizen in our community, okay? In those services, we also provide psychiatric services, like I mentioned. We have physicians either in vivo at our clinic, or we have a telemedicine, which is, the fad right now. We have a lot of different doctors from different areas of the states, or possibly even out of the states, and they see the clients just like they would any person in front of them. They go ahead and do their evaluation, they prescribe them medications, they give them follow-up appointments. And again, all these medications, psychotropic medications, are able to be provided by a PCP, a private doctor, but most of the time our clients prefer to see a psychiatrist because that is our specialty, okay? We do branch out to our PCPs in the community. We go ahead and our medical director, Dr. Rivera, does communicate a lot with them. For those clients that wish to continue with their PCPs out in the community and get those medications prescribed by them, our doctor will provide some of that education and support to them if they need, okay?
I have a comment.
Yes, ma'am?
I don't know when you're going through all those acronyms, what it means. I figured out PCP.
I'm so sorry,
After
yes.
you know, but I don't know where you're going with it, so there were just 2 that I heard.
Our primary care physicians is a PCP, and our ACT, I believe, are assertive community treatment team.
There was an OCH.
LPHA?
I don't know.
OPC. Outpatient clinic.
Yes, I'm sorry, it's our daily lingo, so I apologize for that. So we get to, yes, we have, I know I did mention an LPHA, which is a licensed professional of the healing arts, better well known in our community as a licensed professional counselor, an LPC. So to us, those are equivalent. They provide diagnoses.
We need a directory just for that.
I am so sorry.
For all that everyone's gonna mention, right?
Yes, and thank you for the question. Again, it's just our daily lingo and we just go off on it. But yes, if you do have questions, please let me know. I can definitely clarify for you. Some of these services that we provide once you're an enrolled client in one of our levels of care. Screenings and intake is the beginning, then our diagnosis, which is done by our licensed professional of the healing arts, who gives you a preliminary diagnosis, and then you get a final diagnosis from our psychiatrist. Continuity care services, when somebody goes into the hospital, a psychiatric hospital. Of course, we don't have, unfortunately, well, we have a branch of the San Antonio State Hospital here, but that's usually always full. So most of the time, people who go through crisis end up hospitalized, they go ahead and they get treatment out of Laredo. So our continuity care case manager is somebody who specializes in just that population. Okay, so they go ahead and follow through with them. It's not they get put in the hospital, we wait till they come back. No, we walk the walk with them still through that, and then we transition them back into our community. Some of the other things that we provide, counseling services, we have cognitive behavioral therapy. We know that as CBT for some of us in the field. We have an LPHA or a licensed professional counselor that does that service for them, and that is a special population that you have to qualify for. Jail diversion, somebody in our community that's unfortunately going through the jail system or the criminal justice system, we can still provide services for a short amount of time while they're in there, or if they're on probation and parole, we have specific and specialized caseloads for these individuals as well. So we try to target as many populations and everybody who needs our services, we try to assist them as much as that we can. Of course, there is limitations to it. Our outpatient clinic, better known as OPC, that's where our doctors are at. So that's where they'll see, and it's an outpatient service, so they get to go home, they come back when they're scheduled, they see the doctor, case managers, whoever they're scheduled to, and then they go back home. There's a misconception where it's like, okay, they need to go in, you all need to take them in and keep them there. We are not an inpatient unit, we are not a lockdown unit, we are an outpatient unit, okay? That's yours. I was going to touch on one small thing, the crisis intervention. Ms. Laura Kim touched on the crisis number. We do have that crisis number that's available 24 hours, 7 days a week, holidays, middle of the night. We do work 24 hours a day. Case manager will be dispatched to a local hospital to do an assessment if it is requested by a physician. We do have what's called an MCOT team, our mobile crisis outreach team, who will go out into the community if your loved one is experiencing a crisis. They can go out to the home. We sometimes ask the assistance of LPD to come out with us. Sometimes if we see that the site is not the best condition for us because we want to keep everybody safe, we go ahead and ask them to transport them to the local emergency rooms. We do an assessment, we establish if they need to be hospitalized or not, and then we follow our processes. The one thing I do want to convey to you is that along the way, whichever route the loved ones are having to go through, we walk along with them. We don't let them go, we don't hospitalize them, we don't fold our hands and say that's it. We walk along with them, okay? So if ever you all do need somebody or you know somebody that needs our help, please feel free to call us at the 1-800 number or our main number, 794-3000. And do I have any questions as far as the adult services? Yeah? Okay, thank you so much.
You have 5 minutes remain.
Okay, I will rush through it. Okay, so my name is Gracie Vela. I'm the Director for Substance Use Services there at Border Region. I currently oversee all the education, intervention, and outpatient treatment programs that have to do with any kind of substance use or co-occurring disorders. So the very first one there is the education. So we are a state-approved DWI, which is a driving while intoxicated, and the DOEP, which is the Drug Offender Education Program for the state of Texas. We also have a cognitive life skills. That is something that is very new to Border Region. We offer that particular component to 17 different counties. And so what that is, it's a web-based cognitive behavioral life skills program that the individual is able to log on and take an array of services from theft, shoplifting, substance use, I mean, there's just a variety of curriculums, parenting, domestic violence that they can actually take online. We're able to review the curriculum online, grade it online, everything, even probation officers are able to log on and review also answers. If they're youth that may be taking this particular course, they have to actually have an assigned coach as well. And by the coach, you mean a responsible parent, it could be even an adult sibling, anybody that will be able to go through the course with them, so they don't do it alone. The other thing that we have is the intervention base, and this is offered to all the consumers there at Border Region. If they are identified as someone who has a substance use disorder, we want to assess where they're at. Do they need detox? Do they need residential? You know, are they better fit maybe for outpatient? So we sort of help them with all that. We provide them an array of options, and then we help them and guide them to sort of make the choices that they want to make to be able to get these services. We're very fortunate that we have OSAR there, which is the Outreach Screening Assessment and Referral through Texas Tropical Behavioral Health. They're actually located in-house, so anytime we have someone that needs detox and residential placement, we have the person located on site to be able to screen and assess. And if they don't have insurance, they get placed on a state-funded facility. The tobacco cessation program, that's also offered to our consumers at no cost. They're provided with individual group counseling. They're also provided with the lozenges, the patches, and they actually get monitored every week. What is it called? The CO, it's a monitor that they check to make sure that their levels are going down as well. And that's also offered to them at no cost. We also have the outpatient treatment program, and these are for individuals that may be getting back from residential that want to continue some form of treatment, or individuals too sometimes that do not want to go to detox or residential, or they're just a better fit for outpatient treatment. We also provide them with individual, family, group, and just so to go back, all of the curriculums that we utilize in these particular programs are all evidence-based programs as well. So we're constantly monitoring, our quality management department's constantly monitoring as well. Within our agency, we also have a primary care clinic that all our clients are able to access, regardless if they have insurance or not. So we have a family nurse practitioner there. They get lab work, screenings, anything and everything. As you guys know, with behavioral health, mental health, and substance use, comorbid, you know, that's one of those things that we have to constantly be thinking. They don't just come with mental health and substance, they also come with other medical care needs, right? And so we're able to do all of that there at our sites. We also have the nutrition and healthy living. It's an amazing program. They get the opportunity to do community gardening that we have there. We have art therapy as well. We have yoga classes for them. We have a nutritionist that actually sits with them. So for example, those clients that may not only have the substance, the mental health, but they may also be diagnosed with diabetes and so forth, they get a plan that's designed specifically for them. We've had clients that were on insulin and no longer having to take any kind of medication because they've been able to change the way they eat, they live, and so forth. Okay?
I have a question. I think
Yes.
you just answered a part of it, but
Mhm.
what is the most common reason someone would be referred to do your nutrition and healthy living class?
And it would be that, for example, if they feel maybe that they have like overweight, or they have an acute, maybe a chronic condition, for example, like the diabetes, high blood pressure, those components that we feel that could be monitored through just a change of nutrition. We even have a nutritionist that actually go with them to, for example, to H-E-B or Walmart or anywhere to teach them how to actually shop smarter. A lot of these individuals are on a budget. So they think, easy, fast, processed. And so they actually take them by the hand and they go with them and they teach them how to actually shop healthy. Yes.
Thank you.
Now that you mentioned low budget or needy families, do you require some type of medical insurance, or how do you qualify?
For the primary care, right now, we are very fortunate we're able to provide that service regardless if they have the insurance or not. But I will tell you that we are moving into the component of having a low cost where they'll be able to pay, $5, $10, $25 just to be able to see, because we're actually opening it up to the public as well now. But for right now, for in-house, for consumers of Border Region, we see them at no cost. Yeah. Okay. I'm trying to see if I missed anything. Oh, and then we have the South Texas Traveling Healthcare Team right now that we also have, which is basically a mobile medical team that's out there screening and assessing, and then they actually refer. Some individuals can't make it into our agency. We have a mobile unit that's actually out in the community. And then we're gonna touch bases
Oh,
on when
this
would
one?
be, yes, before we get, what is our time?
You're actually time up, but we can finish your presentation, of course.
For crisis intervention, I know that we all touched on
Yes.
the, pardon?
No, we're,
Oh, I'm
after
sorry.
you're done now, we can open it up for a Q&A.
Okay. For crisis intervention, I know that each of us mentioned the MCOT team, which is the Mobile Crisis Outreach Team. Our crisis hotline being available in all counties, so it's a centralized number, the 1-800-643-1102. Crisis respite services, there's several hospitalizations, but we also offer that as well. We offer crisis intervention training at no cost to law enforcement. So I know that we've conducted probably from the time that I've been there about 2 or 3 classes for our local law enforcement and the different counties that we serve. Then we offer mental health first aid training for both the adult and youth in the schools and the university, again, at no cost. And basically what that is say we don't work in this type of environment and I have a loved one that is going through a crisis of anxiety, depression, but I really don't know who to turn to because I don't know who Border Region is. So therefore, we go out there and educate you. It's an 8-hour course and let you know what signs and symptoms to look for and who to call for help. And the last one is the ASSIST training. It's an applied suicide intervention skills training, and that's a 2-day, 8-hour course. Free.
I have a question. Yes. For the substance use, you said that you have outpatient treatment for co-occurring?
Yeah.
Is that part of the eligibility criteria?
Well, no, they don't necessarily. It just so happens that right now we provide it to Border Region consumers.
Oh.
So there's going to be a mental health.
Oh,
So we want to
okay.
make sure that our counselors are specifically trained on co-occurring. So our counselors are not only LCDCs, but they're also LPC interns, getting supervised through all of that. So we want to make sure that our services are integrated, not so much segregated.
So in other words, they have to be consumers of
At this particular moment,
right now?
yes,
Okay.
yes. But I will tell you the majority of people that go through Border Region end up getting some form of service, regardless if they meet the criteria of those 3 major disorders. You know, they're put in a particular package where they're linked up with someone, so they're not going to leave with nothing.
Yes, that's one of the things that Gracie
Follow
mentioned.
up.
Yes, we do. If you're discharged from a hospital, but you don't meet the criteria that we have for those major disorders, we're not going to just turn you away. We're going to go ahead and follow through with it for a while until we can link you to another service in our community.
And I want just to comment, we've had like wonderful experience with the hotline. We work with substance use and we've used it several times with some of the clients and you all do a wonderful job.
Great.
Thank you so much.
They
That hotline
call
means-
and they screen them on the phone, we have them there, the clients, and they come to scan and actually provide the full assessment.
Yes.
They take care of it. We've had several situations and we really appreciate the work that you all do.
Yeah, well, you don't go only to scan, you've also been out, we work out in the field,
Mhm.
and you've met us there, so.
Yes.
Yes, we
Thank
try
So it's
to,
awesome.
yes, with the
So,
initiative of
thank
knowing
you.
that.
No, yeah, and there's a lot that goes, I think, on behind the scenes and the
Yes.
amount of time and energy that it takes, and so we're
Yeah.
just
We're happy to be able to provide this service because we know a lot of the clients won't come to us. We've
Mhm.
got to go to them. But for
Yes.
safety purposes, we always try to assess the environment and
Mhm.
sometimes get law enforcement involved. When we cannot feel that it is a safe environment, we involved the local hospitals and we go out there.
Yes,
when
and we've had taken them to a hospital, you all go there and, and work together, really, really wonderful job that you all do there. So, thank you. It's a very needed service and we're very fortunate to have it available.
So I'm going to just briefly go over these gaps that we felt were important to just sort of discuss briefly. The very first one was to develop behavioral health partnerships, right? And if you notice, we use the word behavioral health constantly because I think that's and I'm going to get to that as my concern a little bit later. So I'm going to just put my thought on hold there for a minute. But the other thing is building on maybe agency strengths. That's another thing that I think is important for us because we are sometimes we're duplicating services, or sometimes we just don't know about the other agency services, and so That's the other thing. Maybe strength-based, I think employment and vocational programs is so important. I think that's one of the things that we've identified at our agency. Every time someone is discharged, we reassess. And on our reassessments, that's the one component that never really changes. If it was at a 2 when we initially start, maybe it'll go up a 2 or 3. So I know that that's one thing that we need to get, I guess, better prepared. We need to work on it a little bit more. So making sure that we have strength-based employment and vocational programs. Integrative care, making sure that we're not only focusing on the substance, but also the mental health, the primary care component, also the medical, transitional living. I think we've touched on some of these during the meetings that we've held. Of course, the detox and psychiatric facilities. We don't have really one psychiatric facility here in Laredo, I think.
It's just a branch of the San Antonio State Hospital. It
Correct.
does not belong to us.
Yeah, so a lot of times when we do get individuals, we're having to outsource, yeah, and that can be very, very expensive. So that the integrated care or indigent care also to be readily available for clients. But I guess I'm gonna just skip on over to the concerns. I guess it's the stigma. There's definitely a wait list. Anytime we call, especially for state-funded services, there's always a wait list. I think funding and grant opportunities also, I think it's important that we can also develop a site where it's an easy link where all these different types of grants are available to us, because sometimes, for example, the city of Laredo may know about certain grants that may be great for Board of Regents to apply for, but we don't know about it because you're not registered with that particular agency, right? The other thing is the lack of knowledge. I think it's so important too to understand that there's more to an individual than their addiction. Sometimes we handicap, oh, he's an addict or so forth, and there's way more to an individual just than that. And then of course the competing of services. I think, and I'm talking freely. I think sometimes we become very territorial. That a certain agency does this and another agency does that. We sort of need to get away with that, because I always think that if we can just all work together, imagine the powerhouse that Laredo can have, because we do have a lot of agencies that offer amazing services. That if we could just work together and plan things together, it would be so much easier, not only for us, but imagine the quality of care that we'd be providing these individuals. And then the last thing, I'm proposing, is just the possibility of just changing the name from Drug and Alcohol Commission to maybe a Behavioral Health Commission. Because I think, look at Takata. At one time, those that have been around the substance use field, it was Texas Commission of Alcohol and Drug Abuse. Then they changed their name to the Department of State Health Services. It's constantly evolving. And I think if we stick with the name of Drug and Alcohol Commission, we're going to just focus on drug and alcohol. We're going to totally forget about that mental health component, which a lot of individuals have. And so, it's just, I'm proposing, maybe a change to a behavioral health component. And that was that. Thank you.
Let me follow up with a question here. And of course, you mentioned it already, the Drug and Alcohol Commission, and you mentioned there's substance abuse and alcohol abuse programs and outreach programs. And the people that you serve, is there a success follow-up or a follow-up on persons or patients or consumers that you already serviced, and then a visit 3 months from release, or to actually figure out if these people were actually successful and they are not relapsing to their old habits or addictions? And for that, as a follow-up, this commission has been in existence for approximately 11 months. And part of that is not only identify the resources that already exist and educate the public, then take advantage what we have already. Is it possible that you, at the next meeting or follow up, to educate this commission as to how many people has been serviced on substance and alcohol abuse, so we can get an idea that this commission was built already, but nonetheless, the organization's already in place, already been doing their homework, already been doing a benefit for the community, so we can re-strengthen those.
Yes.
Those
I will tell you that yes, those numbers are definitely, the only thing is you'd be looking at numbers that are basically only about a year and a half. Our program is not very new, but I think that I could definitely provide the commission with any information that I can possibly get. And every client that is discharged, they have a 60-day follow-up. But I will tell you, working from a traditional setting, going, and meaning just your regular outpatient treatment programs that are funded by the state, so forth, going into a behavioral health, for example, working with individuals with severe mental illness, the success rate is dropped. Because you're dealing with individuals who feel a little bit better, start taking medications, and then they stay cycle. So I know that there's gaps. There's definitely gaps. So I'm just gonna tell you that those results may not be as promising, but we don't give up. That's the thing. They're constantly coming back, and we're constantly reintegrating them and constantly admitting them, and you know, and identifying too what didn't work. Where could we have gone wrong, or what didn't we prepare for?
Okay, we'll be looking forward to that
Okay.
information.
All right.
very much.
Thank you.
Yeah.
Any other questions?
Madam Chair, if I can add to the question that you brought us, 'cause I think that's important. And I think all those groups are here except Pillar. Because West Care, Scan, Gateway, and Board of Region. Because we were gonna save it to the 5 o'clock when everyone was here. But it's pertinent to what the evidence-based success. The state of Texas has hired a state opioid response director, just opioids, $70 million, 46 from SAMHSA and 20-something from the state, for a total of 70 million. They need to get this out yesterday. And they're gonna be looking at agencies that are already funded, and SCAN is on the list, so you will be getting more funding for the services that you do. But they're looking at communities to give them projects that show success. And that's why that question is important, because they can't get it fast enough. They're gonna contract with universities so they can issue the contracts quicker. If you already have a contract, like, and you're on their list, SCAN is, so you're gonna get more money to do, especially the task force, the mobile crisis task force. These are some things that they've already developed as they're gonna concentrate on. The other is, and Pillar isn't here, who rolled out an naloxone training program for first responders. They've already set up about 12 categories that this is where they wanna put the money fast, no later than February. So you have enough if you already have funding from them, and SCAN's on the list. I didn't see Board of Region on the list, but I think you definitely qualify. But then they're saying communities, if you're doing something in these areas, and one of them is the Crisis Mobile Task Force, submit me a proposal. And it's gonna be handled through the university, not with the state, because the state can't give out monies without a procurement, without a bid, without a proposal, but the universities can. So, and Madam Chair, we invited her to come today. She couldn't, but will come probably in the January meeting. To give an update. She's a friend of the border because she's from Corpus. The Corpus is not the border, but she's interested in seeing, because she knows that the incidence of overdose and drug use on the border is high. And so they want to get these monies out quick, the fastest are current contractors like SCAN, and the other is evidence-based success stories in one of the categories. And so we're anxiously looking at that, because I think the Crisis Mobile Task Force that you all have is one of those categories. Because to get out into the community and address, the other one is what Pillar's doing, the training for naloxone use. And so those practices, but what she said was, tell me your success. Because we're gonna invest in those people who have success, who can show us success. And so that's why the question from Chief Torres was very appropriate, because I think Board of Region has successes. We just need to tell the story. But I think you should qualify for some funding. And I like what you said about, not territorializing it and not, partnering better and building and maximizing resources, which is what the commission wants to do. Is if we've only got this much of resources in Laredo, how do we maximize? And then what are the gaps? And you pointed to some of the things that the commission has discussed. So thank you.
Thank you.
Madam Chair, turn it back to you.
Okay, we will continue with, you want to go back to the agenda now that we have everybody here? Is Ms. Rodriguez here yet?
Is there anybody else that's gonna present?
Well, everyone's gonna present, but
Yeah,
They
at
wanna present at
5.
5.
And the only reason Board of Region, for the interest of those who just came in, went first because they had to leave. If anyone does have to leave, just let the chair know. Otherwise, the stakeholders will present at 5.
Thank you.
Thank you.
I'm staying.
Okay. All right, then I guess we go back to our agenda, which is number 3, possible presentation and possible action on strategic planning. And you had the 2 survey of services and the DAX actual ballot goal survey.
Madam Chair, these were 2 tools you all developed, one of goals and objectives for the commission, and the other
Right.
one is you surveyed the stakeholders, and you heard
From them.
Board of Regents state some of what's already here as the gaps and some of the services. So you wanted an opportunity to go back to this and look at it and discuss it to make sure that the commission was heading toward how do we fill those gaps, how do we address
Right.
those gaps? And then in updating some materials like the directory, how do you get it out? And is it the most user-friendly? You all had a big discussion on that. So today was an opportunity to put some closure on that and take action.
Okay, is there anything that you want to add to the gaps that we saw, and as we just got a good presentation on what was perceived as gaps into what is being done? And yes, as we have discussed, just as she said, we think that as we go forward with this directory and put things together, especially with the gaps, we can maybe do away with we'll get all together, and that if something is being done in separate places, maybe we can put it all together in one, and the others can get their money to something else that's not being serviced, and we can sort of fill the gaps. But we would have to see, of course, I know it has to do with your grant money and what you specifically asked for and what you are tied to presenting or doing. So we have to look at all of the angles before we even try to service the gaps. And even if there's 2 or 3 different agencies doing the same thing, but we're not aware of it because we've never actually tried to put this all together, then maybe we can go through, wait next year for the grants and change some of it. We have to do something about it, and especially we've been given the task of the opioid crisis. So that's where we're trying to get to for the other border person from Corpus. So is there any discussion? Anything anyone wants to say to the commission?
Madam Chair, you all may take some time to look at your packet.
We already looked at this protocol, right?
That's the protocol from SAMHSA on the standard of care for.
That you sent us some time back.
Yes.
I remember reading it.
Madam Chair, there's no doubt that a detox is a priority. I think everybody answered that as a need, as a gap.
Mm-hmm.
And then the discussion in some of your meetings was the type of detox, and that's why
Right.
we gave you the standard, because it is medically assisted treatment detoxification. It's not what some of the discussion members had of isolating the person.
And we need something that has to be a lockdown, right?
Well,
I think they were separate, lockdown and.
But we need to have something that is lockdown.
But we couldn't put them in the same facility.
No,
We
not,
talked
no,
about that.
no, definitely not. Yes, Ms. Dabduk talked about it, right? That we, yes.
You need to be charged with a crime, right? To be in a lockdown facility or be committed, is that?
Well, we had the visit from Sheriff Guerra, right? And he talked about that's where they need help. Because now he's being, we, Webb County, we're being sued because there's already been 2 deaths there. Because when the people are arrested and come in, they deny needing detox and are put in with the regular population and are not being watched as they should be. If they had said, yes, I am high or whatever they're on. And so now because of those several deaths, I think it was 2, he talked about 2, they're in trouble with it, and so they need a place where they can send someone that would have a lockdown facility, not necessarily the jail.
Have we consulted with any other jail areas that may be addressing the substance component in the jails? Like a particular model that they're utilizing?
We were, what was it? We were asking for the different communities, but I don't think it was about the lockdown, right, Dr. Gonzalez? It was not.
They were gonna ask them if they had a detox facility, how they went about starting it, what were their steps?
How they got the funding,
Mm-hmm.
the grants, the go-to. And I'm sure the city could work with, we can't work with any of the agencies, right? That's our right.
Yes.
So then, we need to find out, I guess from other, but it would have to be, we're very unique because we are on the border. And if we contact, say, San Antonio or one of the others, it would not be really what we need to see. They're way bigger. I guess we could go down the valley and contact them to see what's being done.
No, we'd also talked, Ms. Deputy also talked about a location, the blueprinting and all that stuff. Did we talk in depth about that at the last meeting?
No.
No. Then we needed a location, and then we needed to see, what would it look like? It would need to be open. You need to see everybody. You need to see everything.
And just the cost.
Well, that's gonna be the big one.
That's the cost that we have to worry about. And because we deal with Crime Stoppers, I know that our grants are coming up in December. So I imagine that more or less grants start in the January to December, or do they?
September also.
Because of the fiscal year being
Right.
different, okay, yeah.
Madam Chair, one of the things you all discussed was getting the mayor, and he was gonna try to come, and the judge together, because the city cannot address substance use if we don't have a detox center and a medically assisted treatment center, detox center. I think the Shirkwea already and LPD knows that through programs, the SCAN and Pillar and others, they are going in and providing some treatment, some detox, but it's not all.
No.
And so we still do need for those non-adjudicated, and the only ones that can come up with those resources is the judge and.
Yeah, the city and the county.
Well, they're not gonna move without numbers anyway. Statistics, and they're gonna want. I know we talked about it in the past to get numbers and get numbers. Have we ever really got any numbers?
That was my question, because I know in the conversation has been about a detox facility, but at least I haven't seen any data. I know that there were some projections from the OSAR, but they were vague. We haven't seen the actual data, to the need, because if you get a contract, let's say from the state, and you operate on a unit cost basis, then you need to have the facility full in order that you're able to sustain it. So then, I think that what I would recommend is that we start with, what is the need, how many people that are withdrawing as seeking services, and they're difficult to place in Charters Place and Corpus, and do we have enough people that are seeking those services. So I think that has been the challenge, to find out. So
To get statistics.
Yeah, exactly.
And the agencies themselves have these numbers because you're outsourcing and sending them out, is that
Some
correct?
of them, yeah, we come to us directly, majority, they have to go through the OSAR provider, and they do the screening assessment and the placement. So they're able to tell you, they get the bulk of the cases. We need to send, we usually should send it to the OSAR, but sometimes they come with us. If they come directly to us, then we'll make the linkages ourselves to the process.
What is OSAR?
And Madam Chair, I guess that's one thing, we can ask all of the different stakeholders who do provide some service.
To give statistics, but what is OSAR that they were sent to OSAR?
The clients in the system, the substance abuse system, then people have to go to the OSAR provider. They're funded by the state to do outreach, screening, assessment, and referral. They don't provide treatment, so they screen people and then they make appropriate programs. So if somebody comes in, they're not severe, they call us, okay, get into your outpatient program. If they're more severe, but they're not withdrawing, they can link them to a residential program.
Okay.
If they are withdrawing, then automatically they look for a bed outside of Laredo.
They're currently located at.
That's the,
Yeah.
that's the one I was telling you, that we
Okay.
live very close because
Yeah.
we're fortunate that they're located in our
Right
agency.
there. Okay,
But
so
I
that's
can
OSAR.
talk to him to get some data.
Yeah, but actual cases, because I know last time he said, well, they're like about.
Yeah,
7
because he
weeks.
wasn't prepared. I think for that question, he came in just more just to give some form of information, but not so much statistics or stats or data.
How
So,
many people he does refer them to Charlie Springs?
but I'm more than sure he can get you it for all of the, like the South Texas or whatever counties they actually, we just need it for Webb County, right? So,
We're looking at what kind of.
yeah. And then it would be great also, I think, from Wallet, because y'all have that residential program, because like you're saying, sometimes they don't necessarily
We
go
make
through
the
OSAR.
referral sometimes through.
So then if you know that at least you get 15 cases, then you can get something more reasonable, would be like a 10-bed facility, you know. I mean, you want to kind of plan according to, you don't want to ask for a lot of money for a large facility that you're not gonna have.
That you can't fill.
And the detox needs to be at the jail, or
No.
or am I missing it? No, it don't. Have we talked to the city of like the Laredo Medical Center, Doctors Hospital? Because I do know that, I mean, you never know. I'm more than sure they get a lot of individuals that go through their emergency room. They're probably already spending money
Yes.
on these individuals.
Well, but then also they will need to want to come.
Yes, of course, that's voluntary. I mean, yes.
And Dr. Gonzalez, I think you'd be able to address this question, because I think that we've been going back and forth with the whole idea that we come to a consensus that a detox is definitely necessary in our community. But when it boils down to it, is it a city, county funded or grant funded, or is it's a agency supported? Like, how would the detox, what is the responsibility that it falls on the city and the county? And therefore, I think that's primary, like, where do we start off the first step?
Well, I think getting the data together, we've got some already, but finalizing it and presenting it to the judge, to the city manager, because you have to compare the cost of what is happening of taking PD and sheriffs out of duty to arrest someone for possession or being under the influence, taking them to LMC. I can tell you, we've had the discussion both with doctors and LMC, and yes, they do house a partnership they have with Board of Region. And yeah, they're spending too much time and effort and money when we should have a separate. And the programs that SCAN has and Board of Region and others are doing a great job on the treatment and rehabilitation, but the detox and transition, we don't. And Lisa's absolutely correct. Based on the stats, would be the monies to present to the judge and to the city manager. This is what we need: a 15-bed unit, a 20-bed unit, 30-bed unit. I don't think ours would be between, and you all can, between 15 and 30 bed. I don't think we need something larger than that at this point. And I hope we never do. But I think, and that has a cost already. We've already done an analysis for a 15-bed unit from scratch. You're looking at $5 million, brick and mortar and staffing and operations.
Yeah.
And that's just for a 15-bed unit. And that was based because we surveyed other cities as well, of what they're doing. I know you all looked at, and we had a presentation of using the old detention center, but it doesn't fit. It would cost more to retrofit that
Then to make a new one.
than to make a new one,
Or to lease a facility.
or to lease a facility, yeah.
So in regards to the statistics, I think the last meeting or the meeting before, we requested from the stakeholders and the agencies to see how you all measure your success or the services that you all provide in the community. Rather than us giving you all, give us male, female, or what service you're providing, I think you all probably already have something in place. Is that correct? Does SCAN already have something? Does West Care also have somewhat form of measuring success, or?
For our participants?
Yes, or where you're all at as far as providing services to the community?
Yeah, well, Westcare next step right now is in a dilemma. Our grant's ending in October of 2019 for our participants. The only facility that we have here in Laredo for permanent supportive housing for the homeless. So it's ending in October of 2019, so we're in a transition part right now to help our 20 individuals try to transition into
The other resources in the community, but for
and
the
there's very few.
but for the very least, you have the 20 and
We have 20 right
and
now.
you know what category they fall, and you have.
We know where they fall, each one of them, yes.
Could we, and Border Region, I'm pretty sure has the same, Ms. Bella, something where you can show numbers of where we're at. Could we possibly get those to Dr. Gonzalez so Dr. Gonzalez can send it to us prior to the next meeting?
What would be the definition of success?
Well, no, not necessarily success. I use the word success because I measure in my program success in how we're doing. Unfortunately, it's not referred to
Because it
success.
can be increase in symptoms, increase in, functioning. It can be abstinence, what means so that.
Because each stakeholder has a different mission. You all fall into different categories, so you all measure the success of your organization differently. So if therefore you are providing services to youth, then the statistics of how many youth you served and in what areas you served, and again with adult or both male and female and so on, with homeless, and then we have the mental health. So that mental health component. So whatever areas you service, then just get us a number of what your needs are. And then Ms. Bella, if the OSAR is in close contact to you, I think that SCAN definitely gave us the idea of having to get them to provide those numbers, therefore moving forward with a detox.
And so those numbers, would you like for Webb and Laredo, or
The
just
service
Laredo?
area that
Web.
Laredo and Webb.
Webb, I'll tell them to do it for Webb and then to break it down, just Laredo.
Well, I was thinking, there's 7 of us, the committee members. Could we just maybe try to narrow down the 7 most important things that we might need from these stakeholders, and maybe each take a stakeholder and go out and get this information, and we can split up. We can make little mini teams, and we talked about that. But that way, if we can find our top things that we need to present, we can go out and we can focus on finding just those, and it'd be a start. What type of numbers would we need to present to the city manager and stuff? What would be the most important things that they would look for?
Well, I'm done with this because you want data for all the
Yeah, but we gotta-
services, right?
Back up.
And that's the thing that I do see, that we have a lot of services. So the most importantly, I think what we need to look into is what are you doing in prevention, in the aspect of prevention? What are you doing in the form of the other word that was used is education, intervention, and the outpatient or the detox treatment. So in those categories.
And transition, we're worried about transition also.
Well, and that's the gap, that we don't have the transition.
What is, when you said doctor transition, rehabilitation, what were you thinking about?
Someone would go through detox and then transitioning out to residential treatment to then outpatient treatment.
Okay, because we do have the residential already. So then I think that one, we can already say that's what, we really have that piece. Intensive and supportive residential.
Yes, you do have it here on there. You have residential rehabilitation, treatment, and preventive. the detoxification, as Dr. Gonzalez mentioned, as we all know, that is the gap that we have.
Well, Madam Chair, then I think if the different agencies send me their stats,
That should
so we
take care of
can
it.
then present,
Mhm.
it won't, officially should be the judge and the city manager, but we can include both CEOs of the hospitals, because they're interested as well.
Yeah, it's
This is
costing
a
them
heavy
money.
cost for them.
It's costing them money.
And I can tell you, this has been a topic also at the Tri-Medical between the physicians. At the physician, and they just don't know what to do. And they're asking, where do I send them?
So is
I
there-
got one physician who talked to me this week, he said half of his patients have an addiction issue. And so he said, where do I send them? So I gave him the link to the directory. I said, choose, these are all depending on, but they need an initial assessment to treat, but that's going back to what I said about the state opioid director. That's one of the other target areas, is training the physicians to recognize and what to do, because they get scared. They're at the extreme now.
And you know, there's a model they can use, which is expert, and it's brief, it's very short, and it helps them to identify what type of service or linkage. And it's actually, they can get reimbursed too, if I'm not mistaken, if the individual has Medicaid or private insurance. It's a very brief screening.
Well, definitely, we need to train our physicians, because in different aspects. One, many of them are refusing to treat pain because of the potential, but all you gotta do is, I got physicians who were 20 years ago were prescribing 90 hydrocodone pills for pain, and all you needed was a week's worth.
Mhm.
And so people started misusing it. And now, where the contrary, docs don't want to
No.
prescribe. But that is training. All I'm saying right now, I think the 4 key persons to present for a detox are the 2 CEOs of the hospitals, the judge, and the city manager.
Well, if we can get the stats from you guys as soon as possible sent to Dr. Gonzalez, then we can move on this and have it ready by January.
And it doesn't have to be anything that's recreated or done, it's whatever you use within your
And that
departments.
will-
Because then that way, we're coming from, I guess we're all coming from an area where we don't know or understand those numbers, but we wanna make sure that we understand them and then be able to piece them together to funnel them into the resources that the community needs. And so therefore, whatever you have, then we'll find out, okay, well, so why does SCAN have this and why doesn't WestCare have this? Then we start asking and we start, getting more information, which is the reason why we're having, the presentation, so that we can learn more and know what you have. And even at this is actually very good in regards to who you service, what services you provide, and what's necessary, because we can tell what,
At a glance.
at a glance, what and who is doing doing what.
But obviously, because we've worked with grants, we know that grants tie you to what, when you ask for the grant, it says you can use this money for only this and nothing else.
A need and a success, it goes back to that.
But the other thing to this, Ms. Rodriguez has an excellent point, is looking at then those, sharing with the different stakeholders how they each can enhance each other, but getting the word out that these services, and Ms. Dadu presented that SCAN had to go outside of Laredo because they weren't using some of the services, which is why you all went to the directory. But I think, and that's the other thing, so we get the data from the stakeholders so we can have a presentation to the judge and the city manager moving toward the detox. Now letting the whole community know what's there already, and we've got good services from the different agencies, is your directory. And so you all were gonna discuss what else needs to be done with it, and then you had questions of using the webpage, and is it a user-friendly webpage or Facebook, and
Yes,
getting the
because the
information out.
directory is huge.
It's huge, 60-something pages.
And how many
65.
people are gonna take the time to actually read through it? If we can get the way we are hoping, we can do the website itself, and it's user-friendly, and they can type in whatever
Or a phone app.
their problem is.
How did Crime Stoppers do a phone app?
Oh, yeah.
So the way I'm looking at it is, based on what we've discussed, all these things and so forth, one of the things that, of course, a priority is a detox. We've established that there's a need for that. And when I think about clients that come in, and I'm sure also in Puerto Region and other, they come in and they have a substance use disorder, like it's an opioid use disorder, like alcohol severe review, they do need detox, right? The things that, when we screen them, of course, that's where the need is immediate to try to, especially when they, like we said, let's say they want it, like they're asking it there
Help.
and then, please, I need it. And that's where we feel like, yeah, we would like to have, for them to have access to that. And so when they come in, of course, we look at whether, okay, they can have the detox, which is medically managed, or they can use medication-assisted treatment, which is like what AMA does, which is what with medication. If, for instance, for opiate use, right? Because it can be used for other disorders. But so then there, I think perhaps the data will be regarding, those clients that have those disorders, that are the substance use disorders that are in that realm where detox is needed. And then perhaps, the referrals that we have to make outside of that. But that's where I think, because the medication also, sometimes there's a long waiting list for medication assisted treatment as well, that's also a need. And especially for many of the clients that need that, they don't have, that would be also something to consider. As an option.
The need for medication.
Madam Chair, maybe hear me quickly. I just want to let you know regarding the website issue. Brian Pilton has arrived. I called him. I believe we talked briefly through email about him. He's ready with the presentation. What he can do. I'm hoping if the committee is so willing and the city is so willing as well, is he can create for us a website that has a drop-down box where you can select the service you need, how much you can pay or what you have to pay with, and it will generate a list of pulling from this whale of a service list that we have. And anytime you're ready, he's ready to present. I want to let you know that that's available right now.
Okay.
But are we talking about the detox center now, or are we talking about this now? I'm just curious. I had some.
Well, we need statistics from the stakeholders to be able to get information to the county and the city to prove what it is that is needed and what we already have, so we don't duplicate even more, and present this by January if we can. I know we've missed the budget. The budget's October, isn't it? So, but we could at least get the planning stages.
But Madam Chair, in March, they start planning the budget for next year. So
Okay.
it's
We're almost
perfect
there.
time.
Okay, all right.
And let me ask you this: I know that that the committee always had the goal of a lockdown facility type of detox, but from what I was hearing, another type of detox might actually be more preferred with the community. A detox that's open, perhaps for those clients at SCAN or other agencies that know they need the help and want the detox right now. And then from what I think I understood from maybe from Chief Torres and from the jailer is that that there might be a way to get certain people that are arrested to, if they agree to go to the detox, to send them there. So I was curious, maybe we should have a presenter or two just telling us pro or cons of these two different types of detoxes. Because maybe what we need is really an open detox for now, and then maybe later a sort of a lockdown detox. I was just curious. I wanted to throw that out there.
Or wouldn't it be better to enhance the services that the jail provides, so then they can address those medical needs right there and then, instead of having a separate lockdown facility? Yeah.
Madam Chair, I think that was the discussion last time, that yes, support the jail system with individual services to detox there, but but the medical assisted detox treatment center has to be open. And so the programs that SCAN is already working with the jail, the Pillar's working with the jail to go in already and provide treatment and to the persons in jail. Now, if we ever do develop a MAT detox, a medical assisted treatment detox, hopefully with the monies from the county and the city, then someone who's arrested can go detox there and then go back as well. And so there's different options, but right now we don't have an option. The only thing at the penal system is the SCAN program and the Pillar program is having their staff go there, which they're doing now.
But for therapy, we were not doing any
detox.
Yeah.
Yeah, no, I mean, I think the sheriff was pretty clear. They're detoxing cold. Someone has an addiction is arrested. Yeah.
Yeah, I was just curious if we could, because in my mind, I'm not completely convinced, because of what I heard at the last meeting, I'm not completely convinced that that a lockdown detox might be the way to go. I think maybe an open type of detox might be a better service to the community right now if we can get people that are arrested to agree to go to that. And if they leave, then well, they're just arrested. You know, I mean, perhaps we could at our next meeting we could hear from SCAN and they could do a presentation on the parameters of the detox that they're suggesting, and that they could cover. Maybe we can invite someone from the jail to speak about how we could work a program where if someone were arrested, they could have the option of going to the detox. I don't know. I just want to throw that out there. Is that a possibility, or?
Yeah.
It's up to the members, yes.
I think so. I think that'd be good. And I think we need to start inviting, these heavy hitters, the county judge, city manager, the CEOs. We've got to reach out to them and invite them. They haven't even been invited.
Oh, they have been, they haven't come.
They have. The mayor, for example, was invited today and he just couldn't, well, he may show up. He was gonna try. The city manager, has been invited, and so we'll make it a point. Who we haven't invited, but we need to, is the judge.
We definitely work there in the county. We can definitely,
But they're already
reach out.
making the new life arena.
yeah.
So it's on hold because of money.
There you go. There's no money for that, and that's what he really wants. Well,
But I don't even think he knows what's going on here. Like he's,
And one thing to note is
we
that
need to put it in his head.
it will not be a one-time investment, it will have to be yearly
Yes.
Yes.
or
Yes.
indefinitely.
Mm-hmm.
Now to the advantage of Border Region, the judges, the mental health authority, the judge is the last word. And so
okay.
hopefully, the Border Region, they are also educating the judge.
Yeah.
Now, as we were talking about this, do we need a lockdown or not a lockdown? Okay, so the guy's arrested, I don't know what he did, but if he's arrested, he broke the law. How are we gonna let him go without sending a deputy with him to a place that's not locked down?
Well, that's what I would like to hear, but what I'm thinking is perhaps, I'm thinking if they're arrested and they're obviously in need of some services, what we could do is the officer could, I'm assuming he could do this, I want to hear from the police station if this is possible, that they could, take him to the detox center, and maybe they could just have a guard stay there for a little bit to make sure he's detoxed as opposed to sending him to the hospital to detox. Because I know that happens. I know that there are some people that are just injured in some way, they have to get medically cleared before they go to the jail. So we get this guy, I'm assuming this is how it would happen, the officer, and correct me if I'm wrong, Chief Torres, perhaps the officer could arrest the individual who is higher than a kite, take him down until he comes to the ground, and then, at that point in time, he can give him a choice. Okay, you signed this document where you agreed to be in this detox center for so many days, or we take you to the jail. I'm thinking that might work.
It's a great idea. The only thing is that people that are intoxicated does not necessarily mean that they need detox.
Right.
So, if somebody can be drunk and not necessarily go into withdrawals once that is over, or somebody can be high on heroin doesn't necessarily, unless it's a
We need staff at the jail to assist them.
So
Then
then you
that's
need
what I
to
was
do
gonna
an
say.
assessment
A medical
to find out,
assessment.
yes.
So is there in place, do you know of, that the jail has a medical assessment for?
They do, but most of the time when they come in there drunk, I mean, I used to work at the jail, they'll tell you no for everything. They just wanna get in their tank. They do have them, they're good, but the inmates, they're not gonna tell
Well, I
you.
mean, I feel like we need to have that extra step there, at least, at the very
Yeah.
least.
No, I agree.
Because then what Mr. Thompson, and I think it sounds where you're giving the person the decision, the choice of, well, you can go and take detox, so everybody's gonna do I'll just go over there because I don't wanna go to jail. You know, I don't think that that's to their discretion, but rather the justice system, or for whatever case that they might have been picked up for. But I feel that they still do need something. And so at the jail, there is a medical assessment, and at doing the medical assessment, then they either get into a medical tank, right, a medical needs tank, or they go into the regular tanks. Is that
Yeah,
correct?
It would be, it
And we're
would
talking
be
about
best to
lockdown.
do something at the jail, designate a cell where people are being observed, you know, and monitored. And then maybe a nurse that can be there, that will be easier than having a separate program just to hold people that you need to transport and have guards there and things like that.
And the best place would be at the jail, you already have your guards there, you have
Yeah.
everything there, just, and like you talked
So
about, enhancing
monitoring
the
if
services
they take
at
a
the
blood
jail.
pressure.
And as they were saying the last time they came, none of them admit to needing to be put in the cell where they're gonna be watched every minute, and they don't wanna be watched every minute. And so they lie about it, and then they end up,
Or if they start withdrawing, at least they
Yes.
already have staff there to
Sure.
automatically, to render the aid.
And
Well, the
Madam Chair,
thing is, it will have to do the screening, right, and
Right.
at the moment, and how it's done to.
Could you get an
See, my
idea?
understanding is that from the actual tanks that are for medical assistance or for the needs, those are the ones where they have had the fatalities. They haven't been on the upper tier tanks. So the need is still there. It's just having to train possibly the staff to do better, I guess. So maybe perhaps we can get numbers from maybe the sheriff's office in regards to how many people on a monthly basis do they see with a problem, with a need, and then going from there. And do they have it or not?
Madam Chair, Ms. Rodriguez, I think that's an excellent point, and Scan is right too, we do need to assess a medical, the jail already has a medical service. But here's where the training comes in, I don't think they've seen addiction as a health issue. I mean, they call us when they have a patient that's coughing, and we wanna rule out that he has TB. And so we go immediately and assess, and we do have a nurse. I think there needs to be training for them to recognize that addiction is also an issue. It has to be integrated into their medical care service, because it isn't right now.
Yeah,
No one's assessing it.
it should be integrated, definitely.
Because then the next thing would be from there is to find out whether from the stakeholders, is there the resource of allowing an employee to particularly do that type of assessment or taking care of these individuals while they're in there. For the meantime, while we figure out that there's a detox coming in the near future, or in the, hope for in the near future, but for right now, we need to, I guess, concentrate on that.
Well, for the detox, I know that it's more somebody that's specialized for the detox. Usually for Charlie's Place or somebody, I mean, we link them directly. They do the interviews directly. And of course, we may do a screening, a substance use screening, where we can look at history, last time of use, frequency, and so forth. But I do believe that there is, somebody like a nurse or somebody that needs to be also involved. Because it's medically managed. You see, the detox is medically managed. So the input of a medical doctor, I think, needs to be in place. I mean, we can certainly screen, or a licensed professional can do a screening. That's what we do. Because when they come in and we look at what's going on, and if the level of intoxication and all the symptoms and so forth, and we do refer. I mean, we can determine yes, but I don't know if what you think. Okay, if we could.
be part of that.
No, definitely. I mean, if you're looking for training as far as helping somebody gain a better understanding, definitely we can definitely be part of it and help out. I guess on my part, I just want to be clear: are you looking for a detox for the community? Are you looking for a detox for the jail? Are you looking for a hybrid, which I can tell you right off the bat is going to be really, really challenging. So I guess that's just what I'm trying to understand.
It's a detox for the community, but right now, the majority of the need is coming from the jail. So,
Enhancing their services would be, like we said, would be the best
so
option.
for our short-term goals, we would like to concentrate on the jail, and then eventually have where we can work towards a detox for the community that is not a lockdown facility.
One of the things that we could do is help the staff that is at the jail with training, gaining some better understanding of individuals that come in with substance use disorder, what to look for, what tools they can use, and that are brief, nothing major like an assessment type of deal, something that a layperson can use, something like this.
Yeah, and that's what I was asking, if there's any support that you can provide on an instance, just so we can start getting that, because I think Judge Hale Judge Martinez at the last meeting had a really good program already in place. So if we can correlate with that, then maybe we can have, I guess, a success of individuals who are going through all these different tiers and are able to get rehabilitated per se.
But right now, which population would greater benefit? Population that are being arrested or the general public?
So everybody needs it.
Yeah.
Maybe both, and that's why we're kind of torn.
And that's why I propose that, because we already have a jail facility and it's already in existence, and that we see, and I think we could work with them closely while we work towards the community detox center, because that I think is going to be the challenge as of right now with funds and the resources and grants or whatever the case may be to plan it, the planning of that. I think everybody has a really good idea of what the needs are. I just feel like, so that we don't have to spin the wheel again, we just move forward with what we have and what we could possibly do to lessen the problem, and at least with the jail.
Is there a way to find out what the jail is currently doing? Like, for example, do they already have a regimen to address, that someone may need detox? Do they give a medication? Nothing, so that cold turkey.
It's still correct, cold turkey.
Eventually, that's why I think, the programs that already could do something with someone doing a medical assessment. It's training the medical unit. Dr. Garza-Góngora is the physician in charge. And we've had discussions. Again, we've done it with TB. We have to train everybody to recognize what TB is. So now they screen and then they call us. This may be. They're going to have to do the same thing with addiction and screening them so they could go to detox. And so it's training the staff there, because then you have LPCs that SCAN could provide and other agencies as well that could go in.
I mean, I have been in contact with the jail staff. We're already starting to do a jail outreach program with our direct court program. We're going into the jail and we're talking to people kind of like an AA style. I already have the contacts there. Maybe the next step would be just ask them how we can set up a day and time where we can train their physicians. And then we can coordinate with SCAN and whoever else wants to come and be part of that team. I think the thing would be just narrow down who's going to be the ones to actually deliver the training and develop
For
a
a
topic
medical
of
assessment, you have to be a healthcare professional. If you go to region, one of the doctors.
I was gonna say, maybe we could even team up and come up with something. I mean,
And it will
I think
be,
that'd
I
be
think
best.
all
it
of us
will
have
be to at
something to
least
offer.
screen the ones that were drawn from alcohol, and the ones that were drawn from benzodiazepines usually. That the potential for
to do the training,
Well, to do the
the
assessment.
assessment. Okay.
To do the assessment, because it requires treatment.
Okay.
And right now, the only one who has is the physician.
Border region.
Border region.
And see, and that's how I hope that sounds like, hey, because then that's the assessment, because now it's like we're going somewhere. Now it's the assessment, and then SCAN will probably do the training or the support for it.
Now, very soon, the health department, we just started our telemedicine with a psychiatrist 2 weeks ago. We've seen 15 patients already, and 3 of them had an addiction issue. So the psychiatrist prescribed, but it's still too early, but very soon we can add our psychiatrist as well. So that would be an additional. But right now, the specialist for medical treatment is Border Region.
All right, well, let's hook up, and then we'll
And I believe our family nurse practitioner goes there. Because our doctor for the primary care is also Dr. Bongora there at Border Region. So, yeah.
Okay. Are you taking notes, Doctor? We're throwing it all at him.
No, but I think also in regards to responsibility of the members, as Mr. Lozano mentioned, I think maybe we should kind of start doing that, like who's gonna lead certain tasks and follow them, as we had already before, but I think we shrunk them and then we now are developing them again. So I think maybe reviewing the previous minutes and looking at where we're at and what we had decided and what our goals were, because I think we really narrowed it down to long-term and short-term and make sure that we are within that. But I think we need to move it a little bit faster. And I think the jail, prioritize over the jail right now, and then the statistics, and then moving towards the,
Okay, first thing we need is statistics.
yeah.
And that's
To
what we're
understand.
requesting from all of you, to please get them to Dr. Gonzalez as soon as possible.
Yeah.
So we can make that presentation in
Well,
January.
to me, the way that I see it is the statistics determine the need, and then the need determines what kind of size and shape, what kind of design we're gonna have, and then proposals, and we would like to be one of the ones who offer in Border Regions, maybe a proposal. But based on that, then, we can give you numbers and how, so you have different options to see.
And see what we can work with for the 70 million.
From the state.
Yes, that, with you guys, I mean, we have nothing to do with that, but you guys have the authority because of what you provide.
But do you know,
To
Dr.
apply
G,
for it.
since you were there, how they're gonna use that money? Because we haven't heard anything about going to treatment.
Yeah, they're about to roll that out. They have to do it in January, and they're gonna choose current contractors to augment your in those categories. And I'll send you the categories. But one of them is the mobile task force. The other one is treatment, and then they want to try new things. What Shirkwea was saying of putting inmates with addiction to work. That's one of them. These are all pilots, but that there's evidence that it could work. But you'll probably be contacted, SCAN will probably be contacted sometime in January, because if you're a current contractor, they're just gonna increase your funding, because they need to get it out fast. For new, they're gonna have to go through universities, they're the ones who are gonna be issuing the money. And then third, they wanna hear success, evidence-based efforts under those 12 or 10 categories that they have. And according to what she told me, you can submit something and they'll say yes or no. And we'll invite her before January too, the January meeting.
And going back to West Care, you said you had homeless,
Homeless.
and homeless do opioids. I mean, I'm not saying everybody, but that's one of the things that you can maybe work yourself into new money.
Well, we don't do treatment, we just house. We do outsource to Border, to SCAN, to Critter. Charlie's Place. So, that's what we've been doing.
Think of a component to add,
Yeah.
so you can plug into the
Well,
salary.
we could add that, but in order to do that,
A proposal,
yeah,
a proposal,
Right.
not do it,
right,
porque ahorita no hay dinero, but
right.
something that could be added to it to where we don't lose West Camp.
Right.
because we do need everybody's help. Okay,
Madam
well,
Chair, one item before you go to the presentation was the issue that you want to discuss the web.
that's what we're going into next. Yes.
So I'm a little behind here. So with the detox, we're gonna gather statistics, and they're gonna come from scan and image mark, is that right?
Well, for us, like, what we understand is the number of people that we serve for treatment, I guess,
Yes.
for the needs, but then we need more data, more specific to people that have come to you, I mean, to OSAC, not
Yes, for
that I was
detox.
drawing, yeah. And then those are the ones that are released, so.
So then is it safe to say that the numbers that we gather or that we're gonna be reporting are for individuals that needed some form of detox
Yes.
program?
Okay, I thought you wanted numbers and, no,
No.
just the ones that come to us. Okay.
Your service, all services, not
All
necessarily for
services.
detox.
So outpatient residential. food,
Yes.
Women, kids, I mean,
Everybody.
adults, kids.
Yeah.
Move into the presentation, so I wanted to introduce Mr. De La Garza, Ed De La Garza, with Catholic Charities. We were housed there at the facility. We moved out of that facility, there's 20 beds there. So that's something that the committee can consider as far as,
Thank you so much. Thank you for
turnkey
having me
operation.
here as a guest. Benjamin De La Garza, Director of Catholic Charities with the Diocese of Laredo. And Dr. Gonzalez already knows the facility, he toured the facility. So, you know, if there's any possibility that we can also become a stakeholder and maybe provide a facility that can be used for a detox, you know, by all means, you can certainly talk to me or the bishop.
Which would be cheaper than how much? 5.1 million.
Well, their facility that they have was a residential.
Residential.
And so that one is probably more apt, but,
Is that the one we talked about last time, but that it wasn't open?
no,
This
this
is
is
a
totally
different,
different.
brand new?
Totally different.
Wow, it's too.
Which facility was that you're talking about, Mr. Alonso?
Excuse me?
The one that we had.
The one in Callahan?
Yes, 16
Yeah.
Calvin.
Yeah, so that one is not open.
It's 20 individual rooms with an access to showers and then a central kitchen.
But it's a two-story, right now?
It's a two-story.
I mean, because then you have to look in at if they meet the standards.
Right.
For licensure.
It used to be a halfway house.
Yeah, one time as well.
A
Yeah.
long time ago.
La Frontera.
La Frontera,
Yes.
yeah.
Still has the name.
Huh?
Still has the
It
name.
still has a name?
Yeah.
Okay.
I didn't know.
Yeah, I remember
Kept it.
one time ago I used to go, yeah.
Well, Madam Chair, if we're gonna be gathering these statistics from these stakeholders, I would ask that they could put on a presentation and give it to us in writing and kind of tell us what it means towards this detox. Because you know, you hand me some statistics, that's great, but I want to know how it affects what we're discussing. Is that a possibility? So is there a meeting we can have that at? Give them a deadline to get us these statistics?
I think what we're discussing right now in the presentations is the services that they are providing, so what's missing in that component is the statistics part. I feel, unless you all feel
What I
otherwise.
think you want is to get all the data for people that enter, you say to the city and the county here, this is the need. And out of that, so many people need detox, is that what?
Not necessarily for detox, but what we have to fill in the gaps, as Ms. Vela had mentioned. We have a lot of stakeholders and they all are duplicating either resources or services rather, and you all can work together. And then we want to know where the detox component falls in and what the need is so that we can present that.
Yeah.
So we're doing several things within that.
I see what you're saying. I will be glad to see, look at which ones are we duplicating, because I think we have so few resources here in that area. But I don't know that necessarily, everything, at least in terms of treatment,
Yes.
that there's duplication.
The assessment from Border Region with their doctor, how will we start that, or like, you know,
Yeah, just give me a call or email me or stop by, and then that way I can leave you with the proper. Yes.
and that's an assessment that's already in place or something we have to?
No, I mean, there's an assessment right now that is for medical use, which is the expert. So it would just be a matter of training them on expert and then, and of course the signs and the symptoms and everything else. But we can partner up with SCAN and we can work on that component.
Right now at the jail, they're not doing a medical assessment for addiction, for detox. They're not. They need to be trained to do it. And I think there won't be opposed because we've done it for other things as
Right.
well. So it's just training them so they can become familiar and recognize.
Okay, so then, now I'm just trying to catch up to my notes here, then just with the jail, just make sure that we get a date with their physicians, so we can actually sit down and do a meeting. We can do it at the jail, we can do it, outside the jail, does it matter? No? Okay. That's all I have.
Okay. All right, if we're finished with what we need, and as soon as possible, no deadline, ASAP, whenever you have it ready. A deadline would be better.
Tomorrow.
Or at 9:21.
Your next meeting is the first Wednesday of January,
So it would have to be end of the year,
which might be
2 weeks.
too soon.
2 weeks?
2 weeks will be getting close to the holidays.
Very.
Can we do it in mid-January? Is that the second week of January? No.
And really quick, so that, again, we don't want you to recreate or use or do extra work. We definitely don't want you to do extra work. We just want to utilize the tools that you already have so that we can see them. So do you all measure on a monthly, a quarterly, a yearly?
We measure what? Because we can give you numbers, right? Those we give you immediately. If you want follow-up, then results, so you can look at outcomes, then that will be different. That will have to take some time. We look at the different programs, because different federal grants, for example, we do follow-ups at a different rate and put them in a different database. So then we have to pull it all together. That will take, and then also what you mean by success. So then we can look at decrease, for example, in substance use or abstinence, or decrease in depression, decrease in PTSD. What will you be thinking about?
Because you provide all those services, it's technically all of it.
And I think that's what's
So
gonna be
maybe
difficult.
And I think that's where it gets challenging. That's why I'm saying I don't.
Well, we can pull out of the evaluation
Yeah.
reports.
They're from the different agencies.
So then you provide numbers for grants, right? So then can we
We pull out
have
of
your
those.
grants one
We pull out the evaluation reports
from the
our
week
grants.
from the year before?
Yeah.
Because when do you all normally do it for 2018? You would do it after
For
January,
federal grants, we do it twice a year.
Twice a year.
and that would be when?
Every 6 months, and then
Yes, I
the
think it's-
fiscal year, which starts September,
Right now, September.
and then,
Right.
so it's March,
Yeah.
and.
So let's use last
So
September.
let's do the Septembers.
It's already done.
Sorry.
So you want it based off the key measures that we have? That the
Yes.
state has given us, that these are the requirements for you to be considered successful. Whether it's an 80% compliance rate or et cetera, okay.
Lots of numbers, don't give us one.
And don't give us too many, but give us enough to understand.
Now for board
is the
We
idea.
can write it down once we get
We have a lot of
numbers.
behavioral, a lot of
Okay.
mental health, and
Put down
such as.
We'll give you
Down what
something.
looks good.
See, and the way
And
that,
then you only want treatment because we have prevention, intervention, we have counseling.
and that's what it is, prevention and intervention as well. I'll use an example. Crime Stoppers has a way of measuring, how well we're doing, or how bad we're doing, actually. We have how many calls we received and how many calls we followed up, right? And then we go based off of how many rewards we paid and how many picked up. You know, it's a cause and effect as to what happened, what was the outcome and the result of something that was completed. And so that's what, in essence, what we're asking. How many adolescents did you serve, and how many are continuing to get service, and how many need service? Does that, that's kind of sort of what
We'll
we're.
give you what we
You
have.
have.
Yeah, and if you have
It's
questions,
already
just-
done, so give us what you've got already done, and you don't have to go reinvent everything.
Sounds good.
And send it into Dr. Gonzalez, and then we'll work on it. Okay, and then, you will work with them about the training?
About the assessment, yes, and
Yes.
then once we get the assessment and a date, we'll work on, the training,
Okay,
for the
so
jail
we've
staff.
got that one done, so
'Cause
now we
it'd be
can.
two different trainings, right? One for the physicians and one for the jail staff?
Right. It would have to be.
Okay. Then
Would have
Scam,
to be.
you've been voluntold. Okay.
All right, and now we can switch to get the presentation for the.
Can we go next, because we do need to leave in a little while? Okay.
Is that okay?
Can we,
Or the, into the website? The web-
yeah, just so that we can
Go
finish
ahead.
off with the
Yes.
agenda,
Sure.
could we,
Do that one first, because
Can you
I
give me
don't.
about 5 minutes to set up the computer and
Okay.